Hello, it's Dr. Kevin Herman here from American Endovascular and Amputation Prevention. Going to present the case of the month, which actually, it's good that we're in December, as maybe this is really the case of the year. At least could be one of my cases of the year. I entitled this Real Limb Salvage, not that other times we've performed cases with limb salvage, but as we delve into this case, I think this is a tremendous example of the opportunity where we can save limbs that others can't. Patient history and consultation. This is a 47-year-old male. He developed a severe soft tissue infection on the dorsum of his foot. He was on vacation in Las Vegas at the time, and it was told there that he would need to have his leg amputated. You could see the wound image in the lower portion of the slide, which is severe. The tendons are exposed, and this is what showed up at our door just before Christmas of last year. Past medical history was included diabetes mellitus, which was poorly controlled, a history of hypertension. He's not a smoker. His medications at the time, and it's not clear if he was taking all these medications and how often they were being taken, but atorvastatin, amlodipine, Lantus, and nitoglamide. He was not on an antiplatelet therapy at the time. And again, note the age of a young 47-year-old male with poorly controlled diabetes who developed a severe soft tissue infection. At the time of investigation, the plan was for blood work. So one thing we're always looking for is elevated white blood cell count, as well as if there's elevated hemoglobin A1C as a marker for poorly controlled diabetes. We performed arterial imaging at that time, which we'll review the results in a minute. We're going to add an antiplatelet therapy, and most likely based on the arterial imaging and really just based on the clinical picture and patient history, would need an angiogram with likely intervention. Focusing on the left leg findings, because that's exactly what the patient's wound was on the dorsum of his left foot. There was severe tibial disease. The inflow was good at the iliac vessels, at the pelvis, and the femoral and popliteal arteries were providing enough blood flow to the knee level, but from the knee down, it was found to have severe stenotic diffuse disease of all three blood vessels, both the anterior tibial artery, the peroneal artery, and the posterior tibial artery. So urgently, the next day, we went ahead and performed initial angiogram, and that was performed on 12/20 of last year. And you could see in the first image of these are the below knee vessels. The above knee vessels, the superficial femoral artery and the popliteal artery were widely painted, and there were no issues. You can see in the proximal aspect of the posterior tibial artery is an area of severe disease, but it's not horrible as one would come out. But the anterior tibial artery occludes at the proximal portion, and there's also severe stenotic peroneal artery disease. So there's really three vessel disease here. And if you look at the remaining runoff, the posterior tibial artery does have areas of multifocal stenotic regions, and again, with the anterior tibial artery being occluded proximally. More distally, you can see there is what we call nice reconstitution of the posterior tibial artery, which feeds the common and the lateral plantar artery beautifully. But note, this is where the wound is. So all this blood flow, even though it's good, and even on physical exam, there may be a palpable posterior tibial artery pulse. It's just not in the right distribution to the top or to the dorsum of the foot. And so that's going to be our target of intervention, to try to restore blood flow, hopefully in as many blood vessels as we can, but predominantly to try to go and revascularize the anterior portion. And you can see during the angiogram, we were able to bring initially our catheters and wires through what we call the plantar pedal loop. First image is the lateral image, and the second image is the frontal view or the AP view, demonstrating the balloon through the plantar pedal loop. In a case like this, there's multiple various options to treat the patient, whether we would use atherectomy type devices, but ultimately the thing that's going to restore the blood flow is going to be the balloon angioplasty, and these two images demonstrate that we were able to cross through the blockages and typically perform a prolonged balloon angioplasty in order to restore blood flow. And here are the follow-up angiograms after the prolonged balloon angioplasty, where you can see the proximal portions of the posterior tibial artery to have been improved. As we continue along the posterior tibial artery, there is some nice flow distally. There's area of spasm and stenosis, which we can go back and treat intermittently. And we see a nice anterior tibial artery now going all the way down to the dorsum of the foot. Here we now have a fully intact plantar pedal loop. So if you would compare this image to the prior image, you would see there's some excellent flow in the dorsum of the foot. Clinically speaking, about 2 months after, in February of 2021, we have this clinical image of the wound, where the size is decreased somewhat, and we see some well demarcated lesion. However, there's a lot of granulation tissue with slough and exudate, although the tendons are no longer exposed. So that's improved overall. But when we saw him a few weeks later, I really felt that there was a stalling in the healing process. At that time, we performed arterial imaging, and that's approximately in March of 2021, where it showed some recurrent stenosis in the tibial vasculature, but there was actually a new proximal SFA lesion. So there was something going on higher up that was new as compared to the previous ultrasound. And maybe after that investigation, that could be one of the reasons why there had been some stalling in the healing. So we went ahead and performed an angiogram. And I just want to show in the second image, and I can see here with the arrow, that is an area of some abnormal vasculature. And it was not clear to us at the time, but it's possible that during the initial intervention, that's the access site, and sometimes that can become slightly damaged. If you look at the image to the left, from the initial intervention, we can actually see in that area, in that superficial femoral artery region, that was free of disease. So part of the issue with the accessing blood vessels is occasionally you can find there to be some recurrent stenosis or new areas of stenosis that may be related to the initial intervention. It could be new disease, but the important part is to do excellent follow-up with arterial imaging studies and believe your studies. So in this procedure, we actually took a different approach, and we went rather the antegrade approach as the initial time. We went what we call up and over in order to go ahead and treat that. And you can see here at the proximal SFA dissection, we have an area of balloon, which was going ahead and effacing the waist. And we went ahead and were able to efface the waist, but we didn't like the blood flow initially, and therefore placed a bare metal stent in that location to really tack up that dissection and provide optimal blood flow to go more distally. At the same time in that intervention, there was recurrent tibial vascular disease, which we went ahead and treated directly with plain old balloon angioplasty to restore improved flow. You can see here the first image where that anterior tibial artery, which had been an amazing blood vessel after that initial intervention back in December, already a few months later, that disease was recurrent, and which is very common in these type of patients. In fact, oftentimes about 25% of patients do require reintervention. So here we have our before and after images of already after that procedure in May of 2021. There's really good wound healing, borders closing down, and in August, it's just about completely closed. No skin graft was needed. This was all with a little bit of a wound vac and excellent local wound care and vascular care. Here's the before, the initial picture with the tendon exposed after that infection back in December of 2020. And here is a more recent image on the right, a clinical image demonstrating almost complete a closure of that wound, and certainly real limb salvage, as I titled it. So really some of the key components of this case is a team approach. We were in constant communication, both with the podiatry physicians, with the wound care physicians, with the home care agency, as well as the patient themselves. The patient and the family, in certain cases, they really need to be on board with this. It's not immediate. the results are not always going to be immediate, but they do take time to heal those wounds. A wound can happen within 24 hours, and you can have gangrene and you can have infection. But at the same time, really what's very important is to have good communication with the family and expectations. You want close wound care follow-up, and it could be at least every other day on a weekly basis, and also good photographic images of the wound, because as I was progressing, even though if you would describe that wound clinically on a piece of paper and say, yes, it's closed, it's this amount of centimeters less, and the border is well demarcated, there's less slough, you can get a much better, a picture's worth 1,000 words, really, in these cases. And I think it's very important for us who don't see that wound on a daily basis to really have that to compare. And again, the close vascular follow-up is key for limb salvage, because it really enabled us to have our second procedure a completely different approach. And that was one of the key factors. So thank you for your attention. We're very happy to have been able to salvage this limb.